Hello, I'm Keith Fox, and here we are on the last day of the American College of Cardiology Congress here in New Orleans. It's been an exciting Congress, and I'm delighted to be joined by Chris Cannon. Chris Cannon is a professor of medicine in Harvard. Chris wouldn't tell you, but modestly, he has led about 20 major trials that have changed practice. So your insights, really valuable, Chris. You've seen some exciting things at this Congress. You want to chat to us a little bit about these?
Sure. Well, it's been very exciting to see things that change what we do tomorrow.
Yeah.
And just today, the total events analysis from the Reduce It trial were very impressive.
And just stepping back a moment, Reduce It individuals with well-treated LDL who have high triglycerides.
Yeah, and including both the primary and secondary prevention, so broadening the group with documented ASCVD or diabetes and risk factors, as you noted, on a statin with well-controlled, but then if the triglycerides are high, they added the 4-gram dose of the icosapent ethyl, or the EPA-only omega-3 preparation. They had reported a 25% reduction, highly significant first event. But as is amazing to me, they found that beyond that, there's almost double the number of second, third, and fourth events. So another 45% of the total number of events. So there's twice as much benefit as we knew about last time we heard about the trial.
So it's really important for the patients, for the health economics, and so on, to know the impact on total events. But as a trial expert, analyzing subsequent events where your treatment is going to be modified has some biases.
It does, and they have 4 different models, statistical models, to try and do this. Fortunately, the effect is so big that
it's highly consistent.
You don't. So they have a simple thing of the first event is 25% lower. The second event, they just count them up, and there are 30% fewer. Then there's 30% third events and fourth events, and then you remember that over a 5-year period, people have lots of cardiovascular events, and to see the benefit over time is very reassuring that this is a real finding and one that really can impact the course of a given patient. So what's exciting for me is obviously it's been all about LDL, and lowering is lowers better, but then they got everyone to just about 70. And then look at the triglycerides, and then if they're above 135, or I guess it's that 3 millimoles,
yes.
That then you have a second intervention to add to the therapy and get these very robust benefits. So
really,
practical.
Really impressive, practical. Now there's lots of patients out there taking fish oil capsules and taking diets with fish oil in, and they're going to say, well, maybe that's just as good.
So I've had this conversation comes up at least once every afternoon that I have clinic, that people are on it. So we have a poster here that 35% of people with ASCVD are on fish oil of the low dose. That of course has been proven 6 times over to not help. We thought it might, but so then we have to have the conversation with the patient. Well, looking at the triglycerides, it's either not relevant if they're controlled, that they don't need any of those, or if they're elevated, then we have to up to the high dose of the EPA only version.
Yeah.
So it involves education with the patient, but they get it once we explain, this is another add-on therapy.
Yeah, but there's no shortcut in terms of
right, you can't just take 4 of these things from the purity and concentration. I think, dose does seem to be a big factor in this, but then just amazing results.
And Chris, what do you think about mechanism?
Well, it's less clear. There's a lot of science as to what the EPA does in terms of soaking into membranes, stabilizing things,
and maybe making membranes slightly more flexible, more porous.
Right. The effect, interestingly, in this analysis seemed to be a little bit more, the higher risk with higher triglycerides has been seen, so it's a risk marker, and then slightly bigger absolute benefits there. So it has something to do with lowering triglycerides, but there are other things. So as with statins or aspirin or whatnot, we see that it has a great effect, and now we have to figure out exactly how.
Why, yeah.
Same for SGLT2 inhibitors. We're figuring out all the type benefits that can be seen.
But the step change is now understanding that rather than triglycerides being a marker, it's part of the mechanism of risk, and it's possible to modify them.
Right, and a marker of high risk that then this therapy is applicable.
Yeah. Terrific. So one of the other studies that you wanted to discuss was Augustus, because that's going to impact on practice.
It was terrific. So this now gets to a double risk patient of those who have atrial fibrillation needing anticoagulation who undergo PCI. And we've done a lot of work in the intervention area, but these are the highest risk because they need both the anticoagulant and antiplatelet therapy for the PCI. So I've been involved in one of the prior trials showing that dropping aspirin that the Woost investigators dared to do, and we tried it, and that has really borne out as a huge way to reduce the risk of bleeding in these high-risk patients. And so Augustus did a formal 2-by-2 randomization, could identify really in those randomized to not having aspirin that the bleeding risk was markedly lower.
Is worse than double therapy.
But
we don't know for certain,
bleeding,
on bleeding, we don't know for certain whether you could substitute dropping clopidogrel.
Well, you know, the stent will require the P2Y12. I think from the, you know, certainly in the first year, that, you know, dialing back 20 years, that the P2Y12 inhibitor will help on cardiovascular events in a stented patient. This last trial did include some ACS patients, so that's of interest. I think the second part of this is they did, again, a formal 2-by-2, a redo really of all the large AFib trials, that apixaban was far superior to warfarin in terms of bleeding. And to balance this, the efficacy results were pretty similar even when dropping aspirin. So this now is the third NOAC trial to, I think, establish that really in this high bleeding risk and high risk population that the NOAC is really preferred and very evidence-based. This is a big trial, 4,600 patients, so that I think a new standard of care is emerging.
But in fairness, still not sufficiently powered, even though much larger than the other trials, for the efficacy outcomes, even though they looked similar.
It's true, and all the investigators were collaborating on a meta-analysis that's just about complete, and we hope to get out where they're conglomerating the total data set. We may have a firmer way to speak.
Okay, so clopidogrel plus apixaban, full dose, was better than clopidogrel plus VKA, conventional treatment. Do we know if reduced dose apixaban would be even better?
That would be worse. I think and that has been, I think, a key message out of these trials is that the full dose is what provides protection. I think the lower dose with edoxaban was tested and really had a higher risk of ischemic stroke, you know, not in this exact setting. But people have said, oh, it's a high bleeding risk, let's reduce the dose of the anticoagulant, but that's not proven on the stroke prevention side. You know, so a very exciting time.
A really important, thanks Chris. So this is going to change practice and change how we manage these patients. Just finally, let's touch on the prevention guidelines newly published.
Well, you know, one of the big takeaways there is also about dropping aspirin. Here in now a lower risk population, so primary prevention patients at risk have not yet had an event. We had at the ESC and just right thereafter, the AHA, the 3 large trials in primary prevention. Some benefit in patients with diabetes, but some bleeding that seemed about equally balanced.
Yeah.
But then in the elderly and a more general population, really no benefit was seen at all. And so there's a firm recommendation in patients over the age of 70 to really not use aspirin.
Yeah.
And then depending on the risk, to consider it, but have it be a discussion of the benefit-risk ratio. So this is a big change in the US. And we're joking that we're catching up to Europe in terms of figuring out that there is a risk that we have to factor in this low-risk primary prevention group.
Sure.
That ever-present balance of benefit-risk.
But one of the big challenges is where primary prevention actually becomes secondary prevention, and it's occult vascular disease. And that's a tough one, isn't it?
Yes. So this is a very tough one, and we're doing more calcium scores, or can see on imaging that's been done, and there I start to lean more towards using aspirin. But,
so that's really secondary prevention.
It's sort of 1.5 prevention that we do, but to remember there's a real bleeding risk that's kind of fixed, and and age has been a mega factor in my thinking. That that's such a potent predictor for bleeding that's when I really start to hesitate.
Yeah. So a third area that is going to change practice. Aspirin not for individuals in primary prevention, especially in the more elderly, the benefits not outweighing the hazards.
Right, and maybe some, I'd say, still some, but but way fewer than we used to just say, oh yeah, take an aspirin, and I heard it's good, and now it has to be a more reasoned decision.
So Chris, thank you very much. So here we are at the end of the ACC 2019, some really important studies, and studies that are going to impact on practice.
Yeah.
Thank you very much, Chris. That's terrific.
Well, thank you.
Thank you.